most? Any neurologists? Any psychiatrists? Any other? No, okay. Mostly anesthesiologists who will have a good familiarity, as should any pain doctor with local anesthetics, but there's lots of stuff to review. So the tree trimmer is being told, wait a minute, aren't you going to use an anesthetic? Okay, so local anesthetics come in two types, esters and amides. I presume most people have heard of the mnemonic that because there is an I in amide and there is no I in ester, that esters only have one I in the cane part of the word, and amides have two I's. Besides the cane, they have another I in the first half of the word. So all local anesthetics have a lipophilic aromatic ring and a hydrophilic tertiary amine with either an ester or an amide linkage. Right? So they all come with the aromatic ring. They all have this hydrophilic end, and then we have different connections between the two, either the ester format or the amide format. Local anesthetics work by reversibly blocking the sodium channel, thereby stopping the action potential. They also block calcium channels, potassium channels, and NMDA receptors. If you want to know the potency of a local anesthetic, then just find out how lipophilic it is. More lipophilic equals more potent. It has to cross the cellular membrane. It has to get in the cellular membrane and work on the inside in order to do anything. You also should pay attention to where you're injecting because different areas give you higher peak blood concentrations, and blood concentrations are related with side effects. So obviously giving it IV will give you the highest blood concentration, but the next is tracheal, the next is intercostal, and caudal, and the rest of the epidural space, brachial plexus, lower extremity, peripheral blocks, and subcutaneous tissue being the least serum concentration peak. How are these drugs metabolized? So it's different, right? The amides are liver metabolized. The esters are metabolized by plasma cholinesterase enzymes. So if there's a pseudocholinesterase deficiency, you may see a prolonged effect with an ester anesthetic. In a case of severe liver cirrhosis, the amides are going to be more affected, so you see the half-life and the volume of distribution are increased for amides such as lidocaine. Clearance is decreased. In terms of impact of drugs on metabolism, cimetidine and propranolol reduce the liver enzyme activity and decrease the clearance of amides. Barbiturates increase the liver enzymes and increase the metabolism of lidocaine. This is a little unclear, metabolism of lidocaine. What about allergies? So allergies to local anesthetics, true allergies, are a very low risk. The main problem is with esters have a metabolite called PABA, which is para-aminobenzoic acid, and people can be allergic to that. Most likely, if a patient says, I went to the dentist and I had an allergic reaction, they're usually talking about tachycardia and palpitations, probably from the epi that was mixed in with the local anesthetic. So you really have to sort out what they mean when they say they had an allergy. If they seem to have an allergy to an amide, it's almost always the preservative, the methylparaben. But really, as far as I know, people have not described allergies to preservative-free amides. So if you're trying to figure out what to give a patient who gives you sort of a vague history of allergy, and you can't get the details, you might avoid the esters and thereby avoid the PABA allergy, and give an amide that does not have methylparaben. Other issues that can occur. Prilocaine has a metabolite that is an oxidant, which changes the iron and hemoglobin from ferric to ferrous, creating methemoglobin. And that will give you, if you give prilocaine in doses greater than 600 milligrams, you're going to get a pulse ox reading of 85%. The treatment is 100% oxygen, and when you send in a blood gas, specifically ask for methemoglobin levels. If elevated, you want to undo the oxidation, and you can do that with methylene blue. Okay, so in spite of the fact that they are blue because they have a pulse ox of 85, you're going to give methylene blue to treat the oxidation changes of an overdose of prilocaine. Benzocaine and lidocaine have also been implicated as causes of methemoglobinemia, but quite rare. Local anesthetic toxicity has a pretty clear progression from numbness of the tongue and ringing of the ears all the way to seizures and cardiac arrest. So typically it starts with this sort of ringing in the ears, metallic taste in the mouth, numbness in the lips, feeling restless, and you can get toxicity with as little as 20 cc's of 0.25% bupivacaine if it's IV. Higher doses will give you CNS toxicity as seizures, cardiac toxicity. Excuse me. So typically after the CNS signs of activation will come cardiovascular collapse. So we want to see what we can do to reduce the risk of toxicity in general. So ropivacaine and levobupivacaine are safer than bupivacaine with respect to toxicity because they are pure S isomers. And the mnemonic for this is S is the safe isomer and R is the rowdy or cardiotoxic isomer. It's not that S isomers are completely safe, but they are safer. Commercial bupivacaine is a 50-50 mixture. In general, local anesthetics are 50-50 mixtures, except for lidocaine, which doesn't have any symmetry, so it doesn't have a right and a left. Bupivacaine is the most cardiotoxic because it binds to the myocardial sodium channels and only very slowly comes off of them, producing a refractory cardiac depression. Hypoxia, hypercarbia, acidosis, and pregnancy all can increase the risk of toxicity. And again, site matters. Just 1/4 of a cc into a vertebral artery will lead to seizures. Hypercarbia reduces the seizure threshold to local anesthetics. Elevation of PaCO2 increases cerebral blood flow and delivery of the local anesthetic to the brain. Decrease in pH decreases the amount of protein binding, so there's more free-floating local anesthetic in the plasma. So you want to avoid hypercarbia. 2-chloroprocaine is very rapidly metabolized by the cholinesterases, and therefore it has a plasma half-life of less than 30 seconds. And therefore, doses can be given that are very high, 12 milligrams per kilo, because it disappears so rapidly. Therefore, less toxicity. Generally, toxicity goes up with potency, which also goes up with lipophilicity. Bupivacaine is 4 times the potency of lidocaine. Ropivacaine is 3 times the potency of lidocaine. So again, increased toxicity greater than lidocaine because they're more potent. Cardiovascular toxicity typically occurs at twice the CNS dose for bupivacaine and ropivacaine. The toxicity for cardiovascular toxicity is at 2 times doses of CNS toxicity. In lidocaine, the cardiovascular toxicity is 7 times the dose required for CNS toxicity. Okay, question for you. Which of the following occurs as the pKa, which we haven't talked about yet but will, of local anesthetics lowers? So as the pKa number for a local anesthetic drops, which is true? A, the lower pKa is associated with slower onset. B, as the pKa lowers, the percentage of non-ionized molecules, which are the ones that cross the cell membrane, increases. C, the lower pKa is associated with greater potency. D, as pKa lowers, the percentage of ionized molecules, again, these are the ones, well, I'm saying here, it's not necessarily true, which cross the cell membrane increases. E, the lower pKa is associated with lower potency. So the answer is, as pKa lowers, the percentage of non-ionized molecules, and it's the non-ionized that cross the cell membrane, increases. Because there's a greater increase of molecules crossing the cell membrane, it has a faster onset. And it's the speed, not the potency, that you see change with pKa. Okay, so what is pKa? pKa is the pH when half of the drug is ionized and half is non-ionized. That's the definition of pKa. Local anesthetics are all weak bases with pKa's between 7.5 and 9.5. That's the pH at which they're half ionized and half non-ionized, which means at 7.4, which is a pH lower than pretty much all the pKa's, most of the drug is going to be ionized or charged because they've pushed on a hydrogen ion. The lower pKa is associated with faster onset because a lower pKa gets you closer to your pH. Okay, the farther away you are, if you have a pKa of 9.5 and you're injecting that into a body with 7.4, okay, almost all of that drug is going to be ionized and it won't cross the cell membrane very rapidly. But if you've got a low pKa, or let's say 7.5, then you're closer to 50% is non-ionized. That will cross the cell membrane, and so you'll get a quicker onset. The exception to the rule is just dosing, really, is 2-chloroprocaine. It's very fast on, in spite of the fact that it has a high pKa, because we use such high doses of it because it's rapidly metabolized. So it's just doses creating that high speed. Once it crosses the cell membrane, now it's the ionized form. So it's the non-ionized form that gets into the cell, but once it's in, it's the ionized form that blocks the sodium channel. Why do we add bicarb? So bicarb raises the pH of the solution. So now you're bringing the pH of the solution closer to the pKa. You're causing more non-ionized molecules to be present. That has the effect of speeding onset and decreasing pain, the pain of injection. Raising the pH too much, which is why you can't just load your syringe with bicarbonate, will precipitate out the local. So typically for lidocaine, should be a comma here, 1 cc of bicarb is used for every 9 cc's of lidocaine. For bupivacaine, it's typically 1/10 of a cc of bicarb for every 9.9 cc's of bupivacaine. Topicals can be very helpful. So all of these drugs can be topical. EMLA is probably the most well-known. EMLA is the 5% EMLA is 2.5% lidocaine and 2.5% prilocaine. Typically takes 45 to 60 minutes to numb up the skin. It is rarely associated with methemoglobinemia. I think when it has shown up, it's in infants. How does epinephrine prolong the action of lidocaine? That's the question. And the possible answers: A, increasing the ionized portion of the lidocaine. B, interacting with the Schwann cell membranes to reduce the absorption of lidocaine. C, causing vasoconstriction, which reduces localized vascular uptake of the lidocaine. D, causing renal vasoconstriction, reducing renal filtering of the lidocaine. E, blocking the enzymatic breakdown of lidocaine. The answer is vasoconstriction, which reduces localized vascular uptake of the lidocaine. So epinephrine is essentially acidic, with a pH quite low at 2 to 2.5. So when you mix it in, you are causing, it's the opposite of adding bicarb, so you're getting less of the non-ionized local anesthetic, and you're slowing the onset, exactly the opposite of bicarb. By the way, this idea that when local is in an acid environment, you're creating more ionized molecules, so it's harder to get into the cell, is also why local close to an abscess doesn't work well, because abscesses are acidic, and that will ionize your local, making it hard for the local to get into the cells. Lidocaine normally causes some vasodilatation, so the epi counteracts that. Bupivacaine does not have that natural vasodilatory effect. In fact, it has some vasoconstrictive effect. So bupivacaine is not as, you don't get as much bang for your buck by adding bicarb. So you get the more pronounced effects with lidocaine and bupivacaine. If you add it to epidural bupivacaine, it does not increase the duration of the motor block. It only increases the duration of the sensory block, which is sometimes a useful situation. So how much epi can you put into a peripheral block? Generally 200 to 250 micrograms. So you got to get a little bit comfortable in reading the doses on the vial. When it says it's 1 to 200,000, then that's 5 micrograms per cc. If it says 1 to 100,000, that's more concentrate, and that would be 10 micrograms per cc. So 4 milliliters of lidocaine, 40 milliliters of lidocaine, which has epi 1 to 100,000, means that it has 10 mics per ml times 40. It has 400 micrograms, which is more than you would safely want to give, and you may see PVCs or other signs of toxicity develop. You should not use epinephrine if the patient has unstable angina, cardiac dysrhythmias, hypertension. You would not want to use it on a periphery like a finger, a toe, or the penis. Amides. The half-life of amides, so prilocaine is the amide with the shortest half-life because besides the liver, it's also metabolized by lung and kidney. Bupivacaine has the longest, which is longer than ropivacaine, mipivacaine, lidocaine, etidocaine, and the shortest prilocaine. So this just goes as a chart going over what kind of nerves are in a mixed fiber, and we typically see pain as the A delta and the C fibers, and sensory touch, etc., as A beta fibers. All of them are myelinated except for the C fibers. And then you can look at how quickly the effect of a local anesthetic occurs. So typically the sympathetic blocking effects on the B fibers is the first thing to occur. And then pain goes next because the small fibers are the next most susceptible. And then we start getting into motor, sensory, and more motor. What about the risk of seizures? So if somebody is having a seizure, your first order of business is to make sure they have a working airway. It is a situation where you could use succinylcholine if you need to do it in order to be able to control the airway. You want to hyperventilate the patient to decrease local anesthetic levels in the brain. Right? We talked about hypercarbia increases delivery. So hyperventilation will cause vessel constriction, decreasing delivery of local. And you want to, of course, increase the delivery of oxygen. Hyperventilation also induces hypokalemia and respiratory alkalosis, with both of these hyperpolarized the nerve membranes, elevating seizure threshold. And benzos is the typical drug of choice. Local anesthetics bind to protein, and that determines a lot of their duration. The classic protein is alpha-1 acid glycoprotein. Procaine is poorly protein bound, so it's more readily available to be metabolized, and therefore it has a short duration of action. The more protein bound, the less delivery to the fetus. Also, esters have less delivery to the fetus because of their short half-life. So you would like a highly protein-bound ester if you're treating a pregnant woman. Ion trapping occurs in fetal acidosis with amides. So as the fetus becomes acidotic, if they're seeing amides, the amides become ionized by the acidosis, and then they can't cross back across the placenta, and they get trapped on the fetal side of things. Cocaine is a local anesthetic. It inhibits norepi reuptake, which produces hypertension and tachycardias, and generally kind of produces a cardiac irritability. So cocaine and methadone is a pretty dangerous street combination, yet cardiac irritability with the QT prolonging of methadone. Maximum dose for cocaine as a local anesthetic is 3 milligrams per kilo. Question for you. Bupivacaine matches which of the following characteristics? It is an ester, it's slow onset, long duration, with a maximum dose of 5 milligrams per kilo and a maximum epidural dose of 600 milligrams per day. That was just choice A. Choice B, it's an amide, moderate onset, moderate duration, maximum dose 8 milligrams per kilo, epidural maximum 400 per day. Choice C, it's an ester, moderate onset, long duration, maximum dose of 2 milligrams per kilo, epidural max of 600 per day. Choice D, amide, moderate onset, short duration, maximum dose of 4 milligrams per kilo, and an epidural max of 600 per day. Choice E, it's an amide, moderate onset, long duration, maximum dose of 2 milligrams per kilo, and epidural maximum of 400 milligrams per day. That's the answer. It is an amide. It's moderate onset, long duration, maximum dose of 2 milligrams per kilo, very important to know that, and an epidural maximum of 400 milligrams per day. Also important to know if you're the one that is running epidurals on post-op patients. Okay, remember it has two eyes, not only the cane eye, but another eye, so that makes it an amide. Fairly slow onset, long duration, the onset speed is considered moderate. Highly toxic in overdose, therefore 2 milligrams per kilo is the max. So again, we see this sort of slow to moderate for bupivacaine and ropivacaine. Procaine and tetracaine are even slower. Lidocaine and mipivacaine and etidocaine are pretty quick, and the 2-chloroprocaine is very quick. How long do these locals last? So the short ones are procaine and 2-chloroprocaine. And the fast one, those are the short-acting duration was procaine and 2-chloroprocaine. Intermediate is lidocaine, mipivacaine, and prilocaine. And long duration is etidocaine, bupivacaine, ropivacaine, and tetracaine. So if you're going to use local anesthetics, you probably want to have a chart like this around so you know how much you can give. Note that the number in parentheses is a number that you can give if you're mixing epi. Epi, again, slows down the systemic absorption because of causing vasoconstriction, and therefore you can give higher doses. So again, note that bupivacaine is 2 milligrams. A lot of people say you shouldn't really go higher even for ropivacaine. Tetracaine, 1 per kilo. And these more toxic ones don't go up a huge amount when you add the epi. For ropivacaine and bupivacaine, it goes to 3, for tetracaine to 1.5. But these drugs that are more toxic also have longer durations. general rule, I think all anesthesiologists know this because they work with it all the time, is when a medicine is labeled with a percent, multiply that number to find out how many milligrams is in each milliliter. So if something says it's a 3% concentration of medication, that means there's 30 milligrams per cc. Tachyphylaxis is a phenomenon of basically tolerance that develops to local anesthetics. So with repeated injection of local, you can see decreased efficacy. Dosing interval is the key factor. If the dosing interval is short and there's no pain between injections, you generally don't see tachyphylaxis. But if there's a long dosing interval and there's pain in between, then that's when you more typically will see tachyphylaxis develop. As I mentioned, it's available now in patch form, the Lidoderm 5% prescription patch, and now over-the-counter 4% patches. They are indicated for postherpetic neuralgia, but are useful in a variety of neuropathic or localized pains. Typically, you can apply up to a maximum of 3 patches at a time. You got to find out, because with over-the-counter patches, this may not be true for all of them, but for Lidoderm and some of the over-the-counter ones, you can cut them because it's not a reservoir; it's embedded in the patch, and they're typically worn for 12 to 18 hours per day. Okay.